Here we are, and we're all ready to go for the surgical session, the only surgical session we have. And to start off, we have my friend and colleague John Primrose, who's going to talk to us about advances in surgery. Isn't that it?
No.
No.
No, I changed that ages ago. This is the present title, and that's what I'm going to speak to. Well, thanks very much for the invitation. It's great to be here. I've been here 2 years in a row. Normally Helen arranges this meeting, so it's exactly the same time as the main surgical meeting in the UK. But she's seen the light, and it's worked well for the last couple of years. Nobody's interested in surgeons. Nobody wants to give us any money. It's a disaster, but that's just how it is. Okay, so most patients with cancer die of metastatic disease, and so if you're going to improve outcomes, you have to think about metastasis. And this is Stanley Halstead. He thought cancer was orderly, so it was a primary, then it went to nodes, then it went to the next set of nodes, and thereafter, and then it spread systemically. And so if you just did a bigger and bigger and bigger operation, you could get rid of cancer. The reality is this isn't the case, as he proved by doing super radical mastectomies and actually not improving outcome. So very often cancer's in the nodes and it's systemic at the same time, but not always. And the difficulty is, of course, we don't know always which is which. But we need to think about systemic spread when we're thinking about improving surgical management. Now, I'm going to base my talk somewhat on the ESMO guidelines, which have recently been published, and also data from the BILCAP trial, which is probably familiar to most of you. Just looking at the authorship here, actually the majority of people are here. Isn't that fantastic? So an embarrassment of riches on the expertise front in guidelines. So how can outcomes be improved by surgery? We accept that at present surgery is the only curative treatment. We could increase radicality, and will that make a difference? Get more patients to surgery, and then, of course, get more patients through surgery, because these are difficult, large and difficult operations, often with a significant morbidity and occasional mortality. So, talking first about prognostic factors and what we might be able to change by altering surgical management. So this is these are data from the BILCAP trial. You can find all this published in JCO, so I don't perhaps need to look at every aspect of it in detail. You can look this up. Basically, the slides are in a standard format, so it's looking at capecitabine and control, observation only. I think we probably accept the benefit of capecitabine as adjuvant now, but it's looking at a number of other potential prognostic factors. The first one is sex, and this is really quite extraordinary. There is a very considerable benefit if you get cholangiocarcinoma just to be a woman. And why this is not explained. John and I are both involved in a paper that's going to be published shortly, I hope, discussing this. But it's really quite a significant benefit, in fact, very similar to the benefit you get from capecitabine. But in fact, the benefit from capecitabine seems to be, if anything, less in women, but there's still overall benefit to being female. Lymph nodes are a strong prognostic factor, as these Kaplan-Meier show. Similarly, the poorly differentiated tumour. But in this case, you can see most of the benefit from capecitabine adjuvant treatment is probably in the worst prognosis tumours. And then resection status, the R status. R status refers to whether the tumour is up to or separate from the resection margin. And what we try and do is avoid what's called an R1 resection, where the tumour comes up to the resection margin. Not always possible to do, as I will explain. Slightly different format of slides, but basically these are the three different sites of cholangiocarcinoma and gallbladder cancer. And to be honest, there is not a huge amount between them. The prognosis is pretty similar in the long term. Now, this is possibly the most important slide I'm going to show. This is basically the model based on BILCAP. And this is something statisticians to do, and the methodology I would not like to particularly describe to you. But it's looking at prognostic factors in isolation. So it's taking the prognostic factor and taking away everything else and just looking at that alone. So if you look, just for simplicity at the top, the benefits of capecitabine, you've got a hazard ratio of 0.74, quite clear benefit. In terms of site of disease, it's all compared to perihilar HCC, and as you can see, distal and gallbladder cancer are a bit better, intrahepatic probably pretty much the same. Strong effect of adverse effect of a positive resection margin. Performance status, not so much. Females, just being female alone, very significant benefit. Nodes, big effect, and differentiation of tumour, a big effect. So, of these factors, what can you change? Well, you can give the patient adjuvant treatment. I presume that is standard of care everywhere now, except apparently in the Netherlands, where they don't believe the data. The site of disease we can't change. Sex of the patient we can't change. Resection status, maybe we can. Let's talk about that. We can't change whether nodes are present, but whether you take them out or not, we can alter. Differentiation we can do nothing about. So let's just talk about positive resection margins. It's not uniform across all the disease sites. As you can see, it's highest in perihilar cholangiocarcinoma at about 50%, and also in distal disease, less so in the other areas. Now, why is that? Is that because surgeons are rubbish? Not really. It's because often there is just nowhere else to go, and that is the problem. You cannot go further, as I'll try and illustrate. So, maybe not everybody's used to looking at livers. This is a resection for hilar cholangiocarcinoma. This is the liver, obviously. You notice the right side of the liver is slightly odd looking, and that's because the patient's had a portal vein embolization, and I'll talk about what that is a bit later. And in this operation, we're going to leave that bit alone, just that bit, because that is the extreme left portion of the liver, and it's the furthest away from the tumour, and that's how we would most commonly try and do this operation. Now, what are you left with at the end? So we've done the resection. Most of the liver's out. There's a vena cava there. This is the portal vein, left portal vein, and that is the artery. And as you can see, there is just nothing else here. So this patient may have an R1 resection, may have an R0 resection, but there is nothing else here that you can take other than the vessels themselves. Now, I would submit, I think, if you cut out these vessels, reconstruct them, cause the patient a significant increase in their perioperative mortality, the pathologist will find nothing here. So resection margin is not something you can always do anything about as a surgeon. You're basically dealing with what you've got. The other thing is, what does it actually mean? This is, again, data from BILCAP, which is quite interesting. These are not resections, these are R1 resections, and you only need to look at this column here. Again, this is published in JCO. So if you've got a complete local resection, you can see there's a local recurrence rate of 20%. But even in that group, 22% get systemic recurrence and 14% in addition get both. If you look at the R1 resections, more obviously get local recurrence, but also more get distant recurrence, and more have both distant and local recurrence, and fewer have neither. So in fact, it looks to me as if the R1 resections is really just a reflection of bad disease. And there's probably not a great deal you can do about that other than systemic treatment. So usually R1 resections are due to circumferential margin involvement, where you've taken everything you can apart from the vessel, and that's basically it. The bile duct margin you possibly can improve by techniques that I'll describe in a moment, but in many cases, R1 just may be a surrogate for systemic disease, and hence only systemic treatment is going to be of value. Right, so what about lymph nodes? In the guidance, regional lymphadenectomy, taking them all away is standard of care. And this includes intrahepatic cholangiocarcinoma, where it didn't used to be done. And the reason is there is a significant level of lymph node involvement in these patients. And at least for staging purposes, it's important to take them out. Now, it may be that taking out lymph nodes increases the cure rate. Not all patients who've got lymph node involvement who have surgery relapse. So presumably you cure some of them, but by no means all. Now, it's very difficult to demonstrate the benefit of lymphadenectomy, and I'll try and explain this using the Will Rogers effect. Now, he's a comic, so but there's an interesting philosophical point here that relates to cancer. I've written elsewhere about this in colorectal cancer. If you want to look it up. So, who was Will Rogers? He was a comedian in the 1930s, and he had this joke that when people in the Great Depression moved from Oklahoma to California, increased the IQ in both states. Now, how could that be? Well, his contention is the stupidest people in Oklahoma were brighter than the brightest people in California. So if you move the stupidest people from one state to somewhere where they're actually much brighter, then you'll actually improve both the IQ in both sets. And this is basically what in cancer we call stage migration. So if you take out more lymph nodes, you'll find more micrometastatic disease. You'll move patients from N0 to N1, and that will improve the survival in N0 patients, but also improve the survival curve in N1 patients. It won't, of course, make any difference to the survival in the whole group. And if you don't believe this, the sums are pretty conclusive. Look it up in Wikipedia. It's all there with complicated formulas. But any study looking at lymph node resection has to look at whole group survival, not just the ones you've taken the lymph nodes out of. And we believe that positive removing lymph nodes can achieve a long-term survival. So a trial of radical lymphadenectomy is really unlikely to be done. So what are we left with? Probably it's of benefit, but it's really difficult to prove. So getting patients through surgery, the main issues here are, I think we've got to talk about biliary drainage, and this is mainly an issue in perihilar disease, and also how much liver you're leaving. And that's relevant, particularly in perihilar and intrahepatic disease. So, as we actually discussed this morning in the ARCP talk, this is actually quite controversial. I could spend an entire talk talking about biliary drainage. You can do it endoscopically, percutaneously, nasobiliary. You can use metal, you can use plastic. There's really no agreement in the community. Gastroenterologists fight with radiologists, surgeons fight with both, and surgeons fight with other surgeons about how best to do it. And so there's very limited comparative data. So the way I want to handle this is very simple. I just want to be didactic and say what I do and say what you should do, and that's basically it. So for distal disease, I think anything is okay. Any sort of stent is fine. For perihilar, I think transampulary drainage is generally bad, as it can introduce infection into a sterile system, and it may be very, very difficult to eradicate. So what I use for most of these patients, external biliary drainage, bile recycling. Bile needs to be in the gut to maintain the gut barrier, and so basically the patient drinks their own bile. What's the problem with that? So the hospital advice is you've got to drink it with Coke. I personally advise you take it with Guinness. The reason for this is Guinness tastes so bad that just adding bile to it really doesn't make it that much worse. So I usually give them this advice, and what they do at home, well, I don't know. Next problem is ensuring you have an adequate future remnant. Most patients who die of surgery related to cholangiocarcinoma, it's either sepsis or it's basically post-hepatectomy liver failure. Those are the two major causes of mortality. The reason for this is that the amount of liver you're going to leave for these resections is rather small. Generally speaking, it's either segments 2 and 3 or segments 6 and 7. And these segments are usually adequate because they're larger. This often is not so much, and these are the patients that are likely to succumb to liver failure. So in recent years, we've commonly used portal vein embolization preoperatively in these patients. If you block the main venous supply to the liver, you'll get regeneration of the liver that's not been embolized, and so you get a bigger remnant. And more recently, we've taken to embolizing both the venous inflow and the venous outlet by doing double vein embolization, and this increasingly is being adopted in liver centres. I can show you roughly what you do here. So this is a portal venous angiogram with a catheter put in percutaneously, and I can show you basically the procedure being done. I hope so. They basically fill up the right liver with basically stuff that's pretty much like super glue, and that ablates the venous inflow, and you get hypertrophy on the other side. To do the the hepatic vein, usually the right hepatic vein, you use a transjugular approach, and our interventional radiologists do this. Come down into the vein, and then they put a balloon, basically plug in the right hepatic vein. And again, I can show you this, I hope. So catheters down here, and the plug comes out the end of the catheter, which you can see here. And then, then it basically detaches. And so what you end up with is a cast of the right liver and a plug in the portal in the hepatic vein. So what it looks like, this is pre-treatment with a rather small tooth, segment 2-3, and this is post-treatment with an atrophic right liver and a much bigger liver remnant. And in the particular patient I've shown here, they started with a future remnant predicted of about 30%, which is okay but marginal, and it goes up to 40% with the technique. And these patients effectively will not succumb to post-hepatectomy liver failure. And we can see actually in the comparative studies that have been done that double vein embolization actually produces much better volume and functional result. So I think increasingly this will become standard of care. Now there's more to getting patients through the operation than just the surgery, and we've already talked about biliary drainage, control of sepsis, internalization of bile, and the venous deprivation if needed. The other thing to add is that increasingly, and I know Hassan's group do this as well, prehabilitation, that is exercising patients, improving their fitness before operation with a predetermined program. You need good quality surgery, and I absolutely support the need for centralization, not only in large units, but in subsets of those units. So in my unit, 7 of us do HPV surgery, 3 of us do the hilar cholangiocarcinomas. So high quality care, high volume centres, and we also now do double surgeon operating on these patients, because firstly it's a more fun day out and it's much less stressful, and these are difficult operations, and it's better with 2 people who actually know how to do it. And then post-operatively high care environment, early intervention in case of sepsis is optimal. So just in finishing, going over the guidelines and how that relates to what I said. Well, surgery, yep, it's the only curative modality. Diagnostic imaging should be done before stenting or biliary drainage. Hepatic venous deprivation is needed. Strive for an R0 resection and lymphadenectomy. And lastly, and I think Rachel will probably talk about this more in the next talk, liver transplantation is really not indicated outside a small subset and only within clinical trials. So I think there is some potential to improve surgical outcomes, but I think there are limits to this, and ultimately we are faced with the biology of the disease, which we cannot alter. In colorectal cancer and breast cancer, neoadjuvant chemotherapy is commonly used. In bile duct cancer, so far it isn't. You need high quality care in order to ensure patient is optimized before surgery. But ultimately, I think, and I say this as a surgeon, better systemic approaches are needed so that we can move things on to the sort of levels of results that we're getting now with metastatic colorectal cancer. So thank you very much.